Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
Greatest success for the greatest success is actually with the living donor transplants, which have about 10 to 20% better success rate than in other organs. So anyway, those are interesting. And of course, what age can you not donate? Do you know an age you cannot donate? Well, of course, if you're under 18, you have to have your parental permission. And actually, there's no age at which you cannot donate, but there are conditions which make it impossible for you to donate. One is active cancer, and the other is an active infection. But barring those two things, you can be a donor at almost any age. And whether you're an organ or tissue donor is different, because tissue donors can be donated at ages over 80, and living donors also up to about 80. Any questions or comments on it? We got about ready to turn it over to Dr. Christine Nembhard. Dr. Nembhard is joining us today. She's hailing from the beautiful island of Jamaica, where she graduated from the University of the West Indies with a distinction in surgery and multiple surgical awards. She completed her residency training in general surgery at Howard University Hospital, where she was inducted into Alpha Omega Alpha, the Honor Medical Society. Her area of specialization is colon rectal surgery, having completed a fellowship training at the Penn State Hershey Medical Center in 2020. There she obtained extensive experience in treating benign and malignant conditions of the colon, rectum, and anus. She is double board certified in both general surgery and colon and rectal surgery. She's an academic surgeon who is passionate about providing quality patient care. She's an active member of the Association for Academic Surgery, American College of Surgeons, the American Society of Colon and Rectal Surgery, where she serves on multiple conditions. In her spare time, I didn't know she had any, she enjoys gardening, meditation, and spending time with her family. So without further ado, I'll introduce you to Dr. Christine Nembhard, who's our guest today, to talk to us about colon and rectal surgical problems.
Thanks very much, Dr. Callender, and thank you, and good morning to everyone who is a part of the group. I feel very honored and very happy that I was invited to speak with you guys today. And like Dr. Callender said, I'm a colorectal surgeon. So essentially what I do is that I operate on conditions of the large intestine and the anus. So that ranges very widely from anything from inflammatory conditions to cancers to functional disorders of the large intestine and the anus. I essentially evaluate and operate on those patients. And I wanted to talk about two things today. And the most common anal complaint that I get is usually hemorrhoids. And I find that it's one of the most misunderstood diseases as well, even though it's very, very common. And the most feared diagnosis that patients come to me for is colorectal cancer. And that has serious implications on our patient population as well. So let's start with hemorrhoids. And some people may know this as piles as well, but essentially it can be a very, very disturbing problem. But what a lot of people don't know is that everybody actually has hemorrhoids and that they're normal. They're a normal part of the anal anatomy, and we call them anal cushions sometimes. So if you can see my pointer and this image in the upper hand here, if you were to cut your body in half and look at your rectum and your anus, you would see these blood vessels that are right around the anus. They're called hemorrhoids. They're basically like vascular cushions. And they're very useful in terms of keeping air and stool inside the anus. So it helps with your continence. So that's very, very important. But for various reasons, the hemorrhoids can engorge over time, and then they can start to cause problems. And we'll talk about what those reasons are. Some people liken this to varicose veins of the anus and rectum. And you have inside hemorrhoids, which you cannot see. Those are the ones that are likely going to bulge and enlarge. And if they get large enough, they can push out of the anal canal. And you can see them when you're having a bowel movement. Sometimes they go in by themselves, or sometimes you have to physically push them back in with a finger. And then you have outside hemorrhoids, which are on the outside of the anus all the time. And they literally look like these little skin tags or skin swellings. Those typically don't give issues unless there's blood trapped in it. But sometimes they can be large enough to cause issues with itching or getting stool trapped underneath it to make it difficult for you to clean yourself. So essentially, what goes wrong with the hemorrhoids, what causes them to give problems? Well, the number one thing is going to be increased pressure in the anus. So anything that causes any increased pressure, like straining, if you're sitting on the toilet and you have issues with constipation, especially from a bad diet, and you're trying to squeeze the stool out, that's going to engorge all of those blood vessels, and repeated straining is going to engorge them over time until they start to give you problems. In this day and age, we know that a lot of people are spending a lot of time on the toilet, reading papers, or going texting, tweeting, browsing on the internet. That's can be very hazardous because you're spending way too long on the toilet. That increases all of that blood flow is just sitting there on the hemorrhoids as well. We know patients who are pregnant also have a lot of blood flow and a lot of pressure in that area. If you have a job that, or if you did a job where you had a lot of heavy lifting to do over time, or if you had to sit for very long periods of time or stand for very long periods of time, that can also predispose you to having hemorrhoid issues. Also, for some people, it's just hereditary. Their parents or grandparents may have had hemorrhoid issues and they're also having it too, or it can be a normal process with aging. What are some of the symptoms? Essentially, rectal bleeding is going to be the most common symptom. And typically that blood looks like bright red blood, and it comes kind of at the end of the stool. So after you've had a bowel movement, some people will describe dripping of blood into the toilet, or when they wipe, they can see the blood on the toilet paper. Blood that's mixed into the stool may be coming from something else. So that's something that you would have to discuss with your physician. Hemorrhoids can sometimes cause a lot of pain and discomfort. They can cause itching in the rectum. Sometimes there can be a feeling of coldness, especially if the hemorrhoid has grown very, very large. Sometimes it can cause a little bit of issues with you getting the stool out as well. Sometimes just by the hemorrhoid being so engorged and being there, it can cause leakage of stool and soiling of the underwear. Like we said, you can have bulging tissue from the rectum and difficulty cleaning yourself after you've had a bowel movement. So how do you prevent yourself from having hemorrhoid problems in the first place? Like I said, everybody has hemorrhoids, but not everybody has problems with hemorrhoids. So the number one thing, like we said, was increased pressure and straining. So if you can break that cycle, then you're already ahead of the game. So the number one thing that you want to do is avoid constipation and avoid having a hard stool. Essentially, what you can do for this is having a high fiber diet so that you can soften up the stool and bulk the stool. And along with this, it's very, very important to hydrate daily. So you should have at least 2 liters of fluid, as long as you don't have any medical conditions that say you should not be drinking that much fluid. Or some people say 8 cups of water a day. All right. So if you look on the types of stool that you're getting, anything that's these round, pebble-like, hardish looking stools, that's not great. That's going to set you up for hemorrhoids and other issues. But you want a nice, well-formed, bulky, longitudinal stool. Fiber supplementation. So most people don't know you actually need about 25 to 35 grams of fiber in your diet. And that can be a little hard to obtain sometimes, just depending on what your baseline diet is like. We also know that increasing fiber in the diet is really good for heart disease as well. So some of the top fiber foods that you want to include in your diet include things like lentils, beans, peas, whole wheat, bran type things, broccolis, lettuce, apples, avocados even have really high fiber, and oatmeal. And that's some of the example of the amount of fiber that you're going to get with each serving. But a lot of people, I mean, you really have to calculate it, and you really have to go out of your way to get that much fiber. So we mostly recommend that you take a fiber supplement in addition to having a high fiber diet. So some of those supplementations are things like Metamucil, Benefiber, and these are basically all psyllium husk. Doesn't depend the brand name. You know, if you, these are all over the counter things. If you go to the pharmacy, supermarket, Costco, where you have the aisle with the fiber, pretty much anything on the shelf is good to go, as long as you stay within limits. So, you know, some people might be worried for things like Metamucil, the amount of sugar that might be in it, but they make a sugar-free version. These come in powders, they come in capsules, so whatever works for you, just as long as you follow the instructions clearly. And this will help you to really have a nice soft bowel movement. And I tell a lot of patients this, and they kind of don't really, they're kind of like, okay, you know, fine, whatever. And then they go and try it, and they come back and they're like, wow, this really changed my life. So this is something that's really, really super important that a lot of people don't pay attention to. Another thing is good toilet hygiene. So again, we're trying to break that cycle of straining, so that we can reduce the pressure on the hemorrhoids and prevent them from protruding. Another really important thing to do is to shorten the amount of time that you spend on the toilet. Keep it to only about 1 to 2 minutes, so no more toilet texting. Squatting to stool is another thing that is very, very helpful for you to release the stool in an efficient way without pressure. And we know that our ancient ancestors used to do this, you know, before there were any toilets. They probably had less hemorrhoid problems than we do today, maybe because of diet and because of positioning to stool as well. But as you can see in this diagram, most of us sit to stool, and basically you're creating this 90-degree angle. And with that angle, there's a muscle that we call the pelvic floor sling. It pinches off the rectum, and it doesn't really allow the stool to come out in a nice straight line. However, if you were to place a stool underneath your toilet so that you're more in a squatting position, it changes the angle so that the rectum, the pelvic muscle actually relaxes, and the rectum will allow the stool to come out in a nice straight line. So there's some people that are capitalizing on that, such as the squatty potty, but you don't have to buy a squatty potty. You just literally put a box or a pile of books or something. The whole point is that you want that nice squatting position, all right? So those were ways to prevent hemorrhoids. If you're actually having hemorrhoid symptoms, then most people intuitively will go to the pharmacy and pick out something that's over the counter. And there are multiple different creams that you can use, as well as suppositories that you can put into the anus. Tux has cooling pads that you can put on the outside. And these basically all help to relieve any acute symptoms that you might be having, but they're not great for a long-term kind of solution. So if you have hemorrhoids, but you have intermittent symptoms, this works for you. But if you have ongoing constant symptoms, it may not really help you in the long term. Another thing that can help if you're having acute issues, so let's say you're having a lot of pain in the area, or you have that painful, like fleshy mass that's outside that you can't push back in. Another thing that can help you is what we call sitz baths. It's basically warm water in a tub, and you can put it in a bathtub or in a basin, and just, you know, sit in it for about 15 minutes. And that really helps to soothe the anal muscles and helps everything to relax so that the hemorrhoid can go back into the anal canal. Some people will add things like Epsom salts to it. I don't encourage that. There's some over-the-counter products that tell you that they're good to add to water for the hemorrhoids. That's okay if it helps you, but just all you need really is the warm water and just that 15 minutes to soak. Again, if you're having acute symptoms, you should definitely be on the fiber. If you have constipation, you're not able to stool for about 2-3 days, you should take an over-the-counter laxative. And then pain medications over the counter can help, Tylenol, Advil, etc. But when should you see a doctor? We know that, one of the common misconceptions with hemorrhoids is that people think that, it's not that common, that they're the only one experiencing those kind of symptoms. But it really is a very common problem. And basically, we try to let patients know, we alleviate their anxieties and their concerns and let them know you're not alone, because we know that about 50% of the population by the age of 50 years old have experienced some kind of hemorrhoid symptoms. All right. We also know that a lot of people delay seeking care. Only about 4% of patients with hemorrhoid problems will actually come and see a physician. And we want to try to change that. It's very important to get evaluated if, let's say, you're having symptoms and you have no relief, even though you're trying some of the methods that I mentioned before, especially if you're having bleeding from the rectum or constant pain or any change in the color of your stool, or if that anal lump that you're feeling is growing. All right. And it's very important for a doctor to examine you, because sometimes people will come and say they have hemorrhoid problems and we examine them and it actually turns out to be something else. And it can be something more serious, such as like an anal cancer, or it can be, just an anal tear or an anal infection that is treated in another way, not like how they were treating their hemorrhoids before. So if you come to, a colorectal surgeon or general surgeon for treatment on the hemorrhoids, and you've tried the fiber, you've tried the hydration, tried all the over-counter creams, etc., nothing's working, it doesn't necessarily mean that we have to jump straight to surgery. There are some things that we can do in the office to help to shrink the hemorrhoids. So on your left-hand side of the screen here, this is called injection sclerotherapy. It's similar to how people get their varicose veins in the legs injected to shrink them. And it's literally the same thing. We just inject the hemorrhoid and then it shrinks. This works out about 70-80% of the time, but you do need repeated injections for it to really work. And I know what you're thinking, that looks painful, but actually, if you look on this line on the diagram, we call that the dentate line. And anything below that is skin, and you have sensation there. Anything above that is intestine, and if we put a needle there, you won't feel it at all. So basically, you just need a patient who is compliant, who's not very nervous or anxious, who can relax for us to put a tube into the anus so that we can see the hemorrhoid and we can inject it. And usually it's very, very painless procedure, and there can be some mild irritation after, but haven't really had any patients complain. On this right-hand side, this is a laser treatment of the hemorrhoids. It's very similar to the concept of injecting them to shrink them, is that you're basically like causing the hemorrhoids to coagulate and shrink down. And again, you're injecting laser above the line of sensation. So it's something that can be done in the office and you don't really feel it. These do need repeated treatments as well, typically. Another thing that we can do in the office is that we can put a rubber band on it to just basically choke the hemorrhoid, and then the hemorrhoid literally falls off in about 7 to 10 days. When it falls off, it can be like a scab falling off, so there can be a little bleeding with that. But this, non-operatively, this is probably the most effective thing that we can do in the office. And we can do multiple hemorrhoids at the same time. We can do about 2 or 3 of them at the same time. And this is like a one-time shot kind of thing. Similar in terms of no pain issues, as long as the rubber band is deployed above that line of sensation. So when it comes to actual surgery to remove the hemorrhoids, we know that only about 5% of patients who have hemorrhoid issues actually need their hemorrhoids to be removed. We typically offer this for patients who have really, really bad symptoms, or who we've tried other things on non-operatively, such as the injections, the laser, or the rubber banding, and this all failed. or if you have a patient who has severe bleeding from the hemorrhoids to the point that they need a blood transfusion, or if they have a very painful clot that's trapped inside the hemorrhoid and there's no other way to get it out than to remove the hemorrhoid. This is an in and out surgical procedure. And basically what we do is when you're asleep under general anesthesia, we hold up the hemorrhoid and then we cut underneath it, and we basically remove it, and then we stitch up the defect that we made with sutures. And the recovery can be a bit painful, which is why we don't offer it to people. It's kind of like a balance of, are you going to go through this surgery? Like how much benefit are you going to get? So if the benefit is minimal, then we don't offer it. But like I said, if the benefit outweighs the risk, then we go ahead. And the recovery time for this is about 3 weeks of kind of rest and pain medication. But most people who qualify for this and go through this are very grateful. But you really don't want to end up being here if you can help it. All right. So we'll move from hemorrhoids and we'll move a little further up the digestive system to colon and rectal cancer. So this is basically cancer of the large intestine, right? We know that it's the third most common cancer diagnosed in the US, but it's the second leading cause of cancer-related deaths in the US for both men and women combined. In 2022, estimates that we'll diagnose about 100,000 new cases of colon cancer and 44,000 new cases of rectal cancer. And the lifetime risk, you can think of it as if you get a group of 23 people, one person in the group will be diagnosed with colorectal cancer in their lifetime. It affects, it doesn't discriminate. It affects men, women, it affects all ethnicities. But overall, we know that the rate is on the downtrend because more and more people are getting screened and they're trying to, live healthier lifestyles and change their risk factors. But this is a little bit alarming that we also have found that the rate is increasing in some special groups. So patients under 50 years old, we're seeing more and more patients with colon cancer being diagnosed under 50. So colorectal cancer is actually now the most common cause of cancer death in men younger than 50 years of age. And it's disproportionately affecting African American as well, because we're 20% more likely to get colorectal cancer and 40% more likely to die from it. And we're actually also more likely to present at more advanced stage as well when it's discovered. We all know about Chadwick Boseman, Black Panther, who we unfortunately lost to colorectal cancer as well, and he's raised a lot of awareness surrounding this. Now I think more and more people are realizing that this is a disease of younger and younger patients, as well as African American ethnicities. So what are some ways that you can help to prevent colorectal cancer? There are certain risk factors that you can change and risk factors that you cannot change. So things that you can try to change: if you're overweight or obese, if you lead a sedentary lifestyle, so increasing your exercise will decrease your risk. If there's a diet high in red meat, processed meat, and fats, then that puts you at higher risk. So instead, you want to go back to that healthy diet with plenty of fruits, vegetables, and plenty of fiber. Vitamin D, we come through the winter months with lack of exposure to the sunlight. A lot of us have low vitamin D levels, folate levels. You can increase by eating more green leafy vegetables. If you're smoking, you definitely want to stop smoking and cut down on any heavy alcohol use as well. Things that you unfortunately can't change that put you at increased risk for colorectal cancer include getting more advanced in age. If you have any abnormal genes that were passed on to you from a family member who had colorectal cancer, or your ethnicity, you can't change that. So we know that the symptoms of colorectal cancer can be no symptoms at all. So oftentimes it's a silent disease. People are just kind of walking around with it, living their daily lives, and it doesn't really affect them. until when things become a little more advanced, then you can start having symptoms. And some of the symptoms are blood in the stool. You can see changes in your bowel habits. So you can start having issues with constipation where you never really had that problem before. Or you can start seeing diarrhea because if there's a mass there, only loose stool can get past it. Stools that are narrower than usual. Again, if there's a mass there, only small things can pass through that. Abdominal pain, if you're losing weight for no apparent reason, or just like constant fatigue and general just feeling of not feeling well. So what causes colorectal cancer? Even though we have a lot of research surrounding this, it's not very clear in terms of pinpointing one thing. It's a very complex interplay between your environment, what you ingest, your genetics as well. But we know that somewhere along the line, the lining of the colon becomes abnormal. It just really takes one cell to start dividing abnormally. And then it starts to form these colon polyps, which are basically like these mushroom type growths inside of the colon. And then if you leave them there, they can get bigger and bigger and bigger over time. And eventually they can lead to colorectal cancers. So the whole premise of prevention of colorectal cancer is that we want to find these polyps before they grow into cancer so that we can remove them and therefore remove the entire possibility of it developing into cancer. We know that 60% of colorectal cancer deaths could be prevented if the patients had gotten screened. And therefore, colorectal cancer is preventable. And multiple societies, and in particular, the American Cancer Society has now come out and said that all men and women, basically, as long as you're older than age 45, so it used to be 50, but now it's 45 because we know that it's affecting younger and younger patients. When you're 45, you should start getting screened, regardless of whether or not you have symptoms. Remember, we want to find things early before they grow into cancers. For some patients, this age group is a little different. So if you have a family member who was diagnosed with colorectal cancer, then your screening should start at age 40 or 10 years earlier than your relative's diagnosis. So if you had a relative who was diagnosed with colon cancer at age 47, you should start getting a colonoscopy at age 37. And that really holds true for first degree relatives mostly, but even if you have more than 2 second degree relatives, this is absolutely true for you as well. So there are different ways that we can check you for colorectal cancer, and they're all varying levels of accuracy. So one of the most simple things that can be done is that we can send stool tests. And essentially, there are 2 different types of stool tests. One checks for blood in the stool. If you're going to use this as a screening method, it should be done annually. And essentially, it's about 30% good to detect polyps. But if you have an established cancer, it can really only detect it about 80% of the time. And sometimes they come back positive, but nothing's really there because it depends on the diet that you eat. So if you're eating red meat, then it can make it falsely positive. So it's not a great test, but it's better than nothing. Because of this, they made another way to check you in the stool. So I don't know if anybody has seen adverts on TV for Cologuard. That's this little guy here, the blue and white box. Basically, this is prescription only. So your doctor you have to go to your primary care doctor, and then they give you a prescription to get the Cologuard tests, and you send your stool into them, and they're basically checking for abnormal DNA, abnormal genes in the stool. And it says it's 90% sensitive if you already have an established cancer, but the whole premise is that we want to catch things before things develop into a cancer. So if you have a polyp that's about 1 centimeter, you'll get about 57% accuracy result on that. So again, not great, but it's better than not doing anything. We can do a virtual colonoscopy, which is essentially a CT scan that's done every 5 years. And essentially what you do is that you still have to do a full bowel cleanse the day before with a full laxative. You'd still have to do the clear liquid diet. And then you have to drink a contrast as well, so to outline the intestine. Then when you go for your CT scan, you basically, they're gonna put a tube into the rectum, and then they're gonna put some air so that it distends the colon so that they can see, and then they'll take a CT scan. And then here you can see an image of a CT scan, and basically they reformulate it into a 3D image that's like you're virtually doing a colonoscopy. Drawbacks with this is that you need a larger polyp for it to be seen. So the polyp needs to be at least 1 centimeter. And we know the larger the polyps, the more likely it can actually have some cancer in it. The sensitivity is about 50 to 80% on this. But if you see something, you still do need a colonoscopy so that the polyp can be removed. But some patients opt for this because they're a little uncomfortable with the idea of getting a colonoscopy. However, we know that a colonoscopy is the absolute gold standard. It's the absolute best way to check for polyps and colon cancer. And it's similar to the CT colonography in that you have to do the laxatives the day before. You have to do a clear liquid diet the day before. And most people are doing what we call a split dose prep, which means that you drink half of the prep the day before and half the morning of, and that gives you a really good washout. And even a lot of the complaints that I hear about the prep is that it's a large volume of fluid to drink, but there are multiple different ways to prep. They have these small volume preps where you have 2 small containers, and basically you mix them out and you end up drinking about 2 liters of fluid as opposed to the traditional 4 liters of fluid. So it's like half the volume. Or for people who prefer to take tablets, you can take a tablet. It's going to be multiple tablets, up to 20 tablets divided in 2, and you drink about 2 liters of fluid. So it's a more pleasant prep for some people if you prefer it that way. But when you come to do your colonoscopy, it's an in and out procedure, and we definitely usually will have an anesthesiologist who will sedate you so that you're comfortable during the colonoscopy. Most people actually don't really remember what happens during the colonoscopy. You come and you lie on your side, you're sedated, and then we insert a colonoscope, which is this flexible tube, and it has a camera on the tip of it, and we're able to go through the entire large intestine to look and see if you have any polyps. And the advantage of this, and the reason why this is the best way to screen, is that if you see the polyps, you can actually remove them at the same time. And anything we remove, we typically send it to the pathologist to check to see what it is. If you have a colonoscopy that is completely clean, no polyps, you get a stamp of approval and you're okay for the next 10 years. So you don't need another colonoscopy for 10 years unless you're having symptoms. If you have a few polyps, then we say, okay, we'll drop that interval down to about 7 years, 5 to 7 years, depending on how many polyps there are that we remove, because we know that if your colon is making polyps, then you're at increased risk for colon cancer. So we have to keep a more frequent eye on you. So I wanted to look at some of the colonoscopy myths, some of the things that prevent people from getting colonoscopy. So myth, that prep stuff is too gross to drink. Fact, today's bowel prep, basically you can mix it in, Gatorade, your favorite soda or juice, so that it tastes better to you. And then we already discussed the amount of fluid that you have to drink. There are multiple different options now that you can have what's called a low volume bowel prep. The prep takes forever. Nope. You drink half the prep the day before and half the morning of. You split it in 2. It's less bothersome and cumbersome, and you'll get some rest in between that. And most people worry about having accidents on the way to the hospital too, and I haven't really found that that's the case either. It's going to hurt. No, we're giving you a sedative so that you're comfortable. And most people don't really actually remember the procedure at all. They're very comfortable. In fact, I've had patients who have told me that they do not want sedation at all and they want to see everything, and they've actually been awake for the entire thing and they're just lying on their side like they're watching TV. while I'm doing the colonoscopy, and they're pointing out, they're like, oh, that's my intestine. So, it can be that comfortable. I don't need a colonoscopy until I have cancer symptoms. No, we know that the whole premise is that, cancers develop from polyps, and that some cancers don't have, sometimes the colon cancers don't have symptoms at all. Okay, so the whole purpose is that we want to take out the polyps and prevent the cancer before it happens. Getting a colonoscopy is humiliating. No, we're very professional. We respect your privacy, and this is something that is very, very important. And it's like commonplace screening, like getting a mammogram or getting a pap smear. It really is just very common. We do probably about 12 colonoscopies a day in each of our endoscopy suites with the gastroenterologist. So, this is something that's very, very mainstream. I can't afford to get screened. Everybody needs to start getting screened at age 45 years, and the insurance companies are now on board with this, especially now that there are multiple different societies that are pushing for this and recommending this. And in fact, I argue that you can't afford to not get screened. If you do have colon cancer, and ultimately when you get diagnosed, depending on the stage, etc., it can become very, very costly. As opposed to if you had gotten your screening done and they found it when it was still a polyp, then that would have just saved you a one-time thing. So let's say if you do have colon cancer diagnosed, we know that it has a 92% survival rate, but only if you detect it early. Okay. If it's detected, then typically we'll do CT scans to look to see if there's any spread. If we have patients who are younger than about 55 years of age, we'll send them for genetic testing. And that's useful for their offspring and their siblings, just to see if they have any abnormal genes that predispose them to getting colorectal cancer, so that those family members can get their screening at an earlier time. Colorectal cancer is divided into 4 stages. So typically stage 1 to 3 is confined around the colon and the fat around the colon, and those are curable with surgery. Stage 4 is when it's spread to other organs such as the liver or the lungs. And we typically would do chemotherapy first for those patients. And then depending on the response, they could become candidates for surgery. Another myth out there is that a lot of people think that once they get diagnosed with colorectal cancer, then it confines them to wearing a colostomy bag. But that's not the case for most patients. As long as things are diagnosed early, they don't require a colostomy at all. And in fact, if you're kind of delaying with any diagnosis, or if you have symptoms and you're delaying, then you're risking spreading the cancer, intestinal blockage, severe blood loss, or the cancer causing a hole in the intestine. And those are situations that are all emergency situations that would land you in an emergency room. And that's when the increased risk of having a colostomy bag comes into place. So, in fact, 1 in 3 people are not up to date with their colorectal cancer screening. Okay. I did say we start screening at age 45. Usually the recommendation is to go up to age 75 years old, and between 75 and 85 years old, then it's kind of like a gray area that you have to discuss with your primary care physician. Definitely, if you have any symptoms, you still should get a colonoscopy. But if you have no symptoms, you want to continue screening as long as you're healthy and you anticipate that you're going to have 10 more years of life to live, at least 10 more years of life ahead of you, then we recommend that you should continue doing your screening. So your butt is literally on the line. Tomorrow cannot wait. And you should speak with your primary care doctor, speak with your family and friends about it. And this is a very useful tool. If you go to www.getscreen.org, it will actually have you input some of your personal information in terms of determining your risk factor for colorectal cancer. And it will help you to guide you as to what your screening options are. And I think we can take any questions from there.
Okay. Thank you for that excellent presentation that was made as simple as can be. Can we stop sharing the screen and see the people who are online?
Yeah. Sorry, let me stop share. There you go. Second. Okay.
Okay. The floor is open for any questions you may ask. You now can get off mute and ask whatever questions you would like to ask Dr. Nembhard.
Hello, doctor.
Hello.
My father contracted colorectal cancer at age 90, and he had had to have a colostomy bag, and my brother and I learned how to do it, and my father did very well. He went on to participate in the Senior Olympics using a special swimsuit that we obtained online. And he was able to do that with the colostomy bag. And he did so well that the doctors wanted to reconnect him.
Okay.
And he told them that he did not want to be reconnected because he quite liked being able to see his bowels in because all his life he had to reach around, and he liked the fact that he could have bowels.
Oh, it was coming out the front.
Yeah, see what was going on. So they did not connect him. He died, but he did not die from colon cancer. He died from prostate cancer that came back after 20 years.
Okay.
So
Wow.
he died at 93. So my brother and I, for the last for a few years, they had us coming in every 2 years. So now I haven't had any polyps the last 2 times. So they told me I could wait. One doctor told me I should wait 5 years, and the other one said I should wait 10 years. And I'm not. I don't know what is the consequence. Could I keep on doing 2 years, or is that too much? Or
No, yeah, no, that's a great question. So usually when you have a first-degree relative who had colorectal cancer like you do, you should not go more than 5 years without getting your colonoscopy, especially the fact that you've had polyps. I'm glad that your last colonoscopy was clear. So that means that you can stretch it out a little longer. Good. So don't go more than 5 years without getting a colonoscopy, for sure.
The problem that I have, doctor, is that I had thyroid cancer, and when they removed my thyroid, they damaged my parathyroid, so that my calcium receptors were damaged. So I cannot retain calcium. So I take a volume of calcium every day, which makes me constipated, which
makes it hard to prep.
Yeah, well, I eat a lot. I eat about 4 pounds of greens every week, and I cut out red meat, and I have to use suppositories. My problem is I can't I never feel like I've gotten everything. So I use suppositories, and I do use Metamucil, but I can't use it every day because it gives me gas. So I kind of use that every day. So that's kind of the situation that I am in. So that's why I wanted to find out about if I should, because I think that would kind of predispose me to be maybe even higher risk than I am. Am I understanding correctly?
Yeah, the constipation does increase the risk of colorectal cancer, but I think your highest risk is really coming from your genetics and your family history. One of the things with the constipation and the hypocalcemia, that can be very difficult to balance. So I'm sure you've used a lot of various different laxatives, etc.
Right.
And unfortunately, it's a little bit of a trial and error, and just seeing how best you can get your calcium levels controlled. What I will say with the Metamucil, if it causes bloating, then you can switch to a different product called Citracel, and that causes less bloating, because I know that Metamucil does cause bloating for a lot of people. So Citracel would probably work better with your system.
Okay. Thank you
Yeah.
very much, doctor. It's very informative.
Yeah, no problem.
Thank you for speaking with us.
Dr. Nembhard, thank you so much for your presentation. It was awesome. I loved it. Loved every slide that you had there. And of course, Dr. Callender has been insisting me not relying too much on that that annual colorectal screening that we do by mail. You send it in, and because he said it misses most of it. And you went right to that point. I saw the percentages that those tests give. So I'm getting nervous. I'm 72. I had my last exam almost 20 years ago. But you know, and I was one of the people that wanted to watch the exam, and I told him to go really light on the anesthesia on the and I watched most of it, and it was really pretty. You know, I liked it. You know, they didn't find any polyps. And I use Metamucil regularly. But when I was 26, I did have a positive blood in my stool. But at that point, I cut out red meat altogether.
Okay.
I don't eat hamburgers or steaks or anything like that. Maybe once a week, I'll have some bacon or sausage on the weekend, maybe. But fish and fowl are the most part of my diet. I had a couple questions though. When I travel by airplane especially, that's when I had, if at all, hemorrhoids. And I know that I take my preparation H with me whenever I travel. Is that typical, you know, being on the plane and bouncing around? Is that a typical cause of hemorrhoids?
Yeah, no, that's a good question. I haven't heard that question before. I'd have to research it, but I think it depends on how long the flight is. If you're sitting for a very long time, a lot of people who take flights, they kind of alter their bowel movements too. So they might tend to like hold in the stool rather than evacuating the morning of. If they're rushing, things like that can all contribute to it. Or you've been somewhere and you kind of, you know, unfamiliar toilets, and you're not really doing your bowel regimen as you usually do. Things like that can all contribute to it. But in terms of the plane and the altitude, I don't know, but I think it's the prolonged sitting. Yeah.
And one more question. I take Metamucil daily. Is there a timing recommendation? Should you like take it several times during the day or just once? I just take it once in the morning. What do you think?
Yeah, it's kind of up to you and what it does for you. The bottle says that you can take it 3 times a day. For patients who have things like loose stool or diarrhea, I tell them to take it more often, so up to the 3 times a day, because it helps to thicken the stool. But if you're taking it for constipation, I'd say once a day, usually a scoop in juice in the morning. Just make sure you drink the whole glass of water so you get your hydration as well. You know, sometimes for me, I take mine at night, so it depends on what works for you. Sometimes there are certain medications that if you take it with fiber, the absorption might be different. So if you take your medications in the morning, maybe you want to take the fiber at night. So these are all different considerations. But for most people, generally, if you take it 1 dose in the morning, you're good to go.
And last question for you personally. How often do you see an emergency that you have to go in for surgery?
Emergency from colorectal cancer.
Yes.
Yeah, more often than I'd like. I think unfortunately, because we've been through COVID, and at the beginning of COVID, we weren't quite sure, what to do with patients who weren't ill, who wanted to just get their screening colonoscopies. So there've been a lot of delays with that, and with patients not wanting to come into the hospital as well because they don't want to expose themselves. But now we have more protocols. Our screening is kind of approaching our pre-COVID numbers. But unfortunately, because of this, I do see. In the past month, I've had to deal with about 3 bowel emergencies from colorectal cancers. So I'd like to see that, go down to 0, but you definitely don't want to be that person. So colonoscopies, I'd encourage you to get your screening exam done soon.
Thank you so much. I had an endoscopy last year, and that was okay. So
awesome.
I will follow up. Thank you very much.
Oh, you're welcome.
I have a question.
Yeah.
Number one, I apologize. I was late logging on, so if you've already answered this, again, I apologize. I'm due for colonoscopy next year, which would be 5 years for me. 2 questions. Number one, what's the normal frequency? And number 2, if during a colonoscopy you have polyps removed, does that, and it turns out that it's non-cancerous, but does that mean it will increase the frequency, or will it still remain the normal time frame?
Yeah, no, that's a good question. So if you have a colonoscopy that's normal, the next interval is going to be 10 years, all right? That's provided that you're what we call average risk, which means that you've never had polyps before, you don't have any family members who have colorectal cancer, and you don't have a personal diagnosis of some kind of like inflammatory bowel disease like Crohn's or ulcerative colitis that would increase your risk, right? So every 10 years, all right? If you have a colonoscopy and they see polyps, it depends on the number of polyps that they see and remove. So if they see 1 polyp, and it depends on the type of polyp as well, because not all polyps are equal. Some are precancerous, but some actually are just kind of overgrowths and they're just perfectly benign and will never turn into cancers. So if you have the benign ones that never turn into cancers, then you can go 10 years. But if you have the precancerous type, if you have about 1, then they'll tell you to get a colonoscopy in 7 years. If you have more than 3, they'll tell you to come back in 5 years. All right. And in 5 years, if your colon is completely clear, if you're still average risk, then you can go up to the 10 years.
Oh, okay, good, thank you.
Yeah.
All right. My hand is up. Hello, good morning.
Good morning.
Yeah, Dr. Nembhard, thank you very much for a wonderful presentation. I enjoyed the presentation so much. It's awful with all the slides, depicting all about colorectal rectal cancer. Thank you very much. Now, I've been taking metamucil for about a month or a little more month, because I have been having constipation for a long time. But what I was taking initially was prune juice. I don't know if you're familiar with prune juice.
Yeah.
Just like in my own case, when I take prune juice, like a glass full, I have, it gives me bowel movement. I go to the bathroom and my stool is watering, So that's what I used to take. But when I stop taking it, then my stool gets hard. So I have, they have tested my stool for colon cancer, and then it came out negative, last year. So since my stool is always hard, and then I started taking metamucil. So what do you recommend to be taking? Somebody advised me to be drinking prune juice every day. instead of drinking Metamucil, every day, I should
Mhm.
repart. So what do you think about the two ideas?
Yeah. When you said you had yourself tested, did you have a colonoscopy or did you send
Two
in a
tests,
stool test? Sorry?
two tests, two.
Yeah.
I submit two for
I
tests.
think you should get a colonoscopy just to be 100% sure that there's no mass or anything blocking things up. That's the first thing I would say. And if that's all fine, then keep doing the fiber, the Metamucil. Make sure you're hydrating with it. So you have to take a lot of fluids, because if you take just the fiber and you don't drink a lot of fluid, then it can worsen the constipation. All right. And there's nothing saying you can't do both, the prune juice and the Metamucil. That's fine. You may want to drink like half a glass of the prune juice instead and see if that combination works out for you. And you can adjust the amount of prune juice from there if you need more or less. Yeah. If you want to try other things, there are other things over the counter that you can use, such as Miralax as well. Um, you know, but I would say just make sure that you get a colonoscopy and that you take that off the table first as a consideration.
Okay.
Okay.
Dr. Nembhard, I have a question.
Yeah.
But first I wanted to thank you for your presentation. I learned a lot in a short period of time.
Awesome. Good to know. Good to know.
Okay. My question is, what is meant by change in bowel habits?
Yeah. Yeah, I should have elaborated on that. That means that, if you've been routine most of your life and all of a sudden you find that you're constipated or you're having loose stool, or let's say in a week, 2 days out of the week, you'll be constipated, but the other few days you'll have loose stool, then it's like erratic bowel movements, kind of.
Right.
Yeah. Because the constipation, if you have a mass there, could mean the stool's not coming past it. And the loose stool could mean if there's a mass there, that only liquids can get past it. It's like a blocked pipe, essentially.
Mhm.
Yeah.
Thank you.
I have one more question.
Yeah.
Is it a must that one should stool every day? Does the amount of food you eat depend on the frequency of going to stool? Somebody was telling me that you must stool every day. So I was little, because they say some days I don't eat eat that much, and the following day I may not stool. So
Yeah.
what is your take on that?
Everybody's different. For some people, normal for them is stooling 3 times a day. And for other people, normal is stooling 2 or 3 times a week. I would say if you're going a whole week and you only had 1 or 2 bowel movement, that's abnormal.
Okay.
But you don't have to poop every day. No. Yeah.
That was going to be my backup question also.
Oh, I
One
think
of
you
our-
typed it in the chat. Or?
Yeah, one of our regular members, Darryl Armistead, who's a vegetarian, I think, or vegan, he said you should be going 2 or 3 times a day, but that really depends on several other things, like your diet and
Yeah.
other things. Maybe you should elaborate on that though a little bit.
Well, my brother's a vegan. He goes 3 times a day. I think that if you're eating more like vegetables and you have more bulk in your diet, then you're gonna go more often. But if your diet's like, McDonald's kind of fries, nuggets, or the typical Western diet, kind of low fiber, not too much substance to it, a lot of processed things that take forever for you to digest, then you're gonna go less frequently. Yeah.
And there's a lot of different vegan diets. Just because you're vegan doesn't mean that you're on a good diet, because you could be loading up on fried foods.
So, yeah, true.
So, it depends on, there's a variety of fiber levels that you can have with a vegan diet.
Dr. Callender says that you should have a bowel movement every day.
That's correct. But I'm not a colorectal specialist.
Yeah, I mean, I think that's the ideal to aim towards, not a calendar. So I wouldn't disagree with you in that regard. I think that we should just delete the files daily. That's ideal. But for some people, that's kind of just how their body is. They don't go every day, and as long as they don't have symptoms related to that, they're not having abdominal bloating and diet intolerance, etc. Then that's kind of what their normal is.
Well,
Dr.
most
Nembhard, is it possible to have cancer without polyps?
Yeah, great question. It is, yeah. Some patients who have inflammatory bowel disease, ulcerative colitis, Crohn's, it increases their risk of cancer, and that's because there's just so much inflammation in that area that the cells are constantly turning over, and it just takes one cell error to cause that. But most cancers start as polyps. Most of the colorectal cancers start as polyps. Yeah.
Thank you.
Yeah, most of us from Africa, we are high in starchy food, like carbohydrate, rice, plantain, cassava. That is our main staple food. Not so much on vegetable like greens, and then meat. So is it of advantage or disadvantage?
The carbohydrate
Yeah.
starchy diet.
Yes.
I don't think too much of anything in isolation is going to be good for you. I think you should make a good effort to balance that out with getting some more vegetables and some lentils in there with it that will add the fiber in for you.
Dr. Nembhard, I'm looking at an article about 7 foods that can cause constipation. It says alcohol, gluten-containing foods would be primarily breads, processed grains, milk and dairy products, red meat, fried or fast foods, and persimmons. What's your take on that?
No, I agree with that. I don't know. I didn't know about the persimmons. The persimmon fruit.
Yes.
Okay, that's interesting to know. But for sure, fried, fatty, processed things, starchy foods for sure. If you kind of refer back to that list with the high fiber foods, even avocados have high fiber. That's something that was very interesting. Lentils, certain grains, but gluten also does play a huge issue, I think, with people's diets, as well as dairy, lactose containing things. I try to avoid gluten when possible. Some people have like, gluten enteropathy, like a special diagnosis because the gluten causes a lot of inflammation in their intestine. But limiting gluten and wheat is, I think, would benefit most people. But it just depends. I think in general, trying to balance everything and trying to ensure that you're, actively trying to get more fiber in your diet would be my number one recommendation.
Yeah, it seems to me that American diet has a love affair with breads, particularly with our love of sandwiches. And to get all that bread and gluten in your diet, my personal experience is that your digestion is better off without it. Let's face it, we all like the taste of bread, but I try to limit it to maybe once or twice a week, but not a daily thing.
Yeah, I try to limit my bread intake as well, and pasta and wheat containing stuff. I mean, unfortunately, one of the other things is that if you go to the supermarket and you go looking for gluten-free products, they tend to be more on the expensive side. So that's kind of an unfortunate state of affairs in terms of trying to get the general population more healthy too.
Dr. Nembhard, you just mentioned pasta. Can you say something about pasta more?
I think that's the most I know about pasta. I don't eat too much pasta. I don't delve too much into it. But if there's wheat and gluten involved, then I stay away from it. The type of pasta that I try to use is like rice-based noodles, or it's made from like plants. There are different pastas that are made from plants, such as like heart of palm pasta, things like that. Um, if I feel for pasta, that I'll eat that, but I try to stay away from the traditional. There are pastas that they make from lentils as well, and from like different vegetable substitutes. So I mean, it's not gonna taste the same, but it's healthier.
Yeah, yeah. I try to avoid the gluten pasta, so I'll eat the brown rice and lentil pastas. Just in the preparation, I find that probably need to boil it an extra minute rather than the wheat pastas. If I'm doing boiling it for 10 minutes with a brown rice pasta, I might tend to boil it just depending on the brand for 11 to 12 minutes.
Mm.
Uh,
This is a great group. I love it. You guys, I'm learning stuff too.
I have another question about red meats and staying away from red meats, like a nice 6-ounce thing of filet mignon, you know, 6 ounces. Exactly what does it do to the digestive system? Is it the fact that we have a hard time or a long time digesting it? Is that it?
That's exactly what it is. You know, the longer things take to process and move through the intestine, it's more like stagnation, and it gives the cells more opportunity to become abnormal.
Hmm.
Yeah, I mean, you hit the nail right on the head. That's exactly what it is.
Oh, so what you're saying is a 6-ounce piece of well done filet mignon, you know, is not what we should be doing.
To be avoiding it, yeah.
Yeah, you should be avoiding routine. I mean, I think once in a while, that's fine, you know, but if you're doing this like very frequently, then, and that's your lifestyle, it's not going to be great for your colon health or your heart health.
My brother-in-law, he gets surrounded by dreaming about eating a T-bone steak. You know, he
Okay.
dreams about it, and that's how he eats red meat.
Mm. Yeah, I mean, it's like, you know, like alcohol in moderation. It's, you know, there's nothing wrong with eating nice things. You know, these are nice, like tasty things. It gives you that nice dopamine rush and that satisfaction. But it can be, you know, too much.
Mhm.
Dr. Nembhard, can you tell us a little bit more about the preparation for colonoscopy in terms of how can it be made less painful and less unpalatable?
Yeah, I know. I tell patients that I have a lot of karma coming back for me for when I have to start doing my colonoscopies, because you know I've tasted the pep before. It doesn't taste that pleasant. But one of the things that you can start to do is put it in something else. So put it in like Gatorade or apple juice, cranberry juice to kind of mask the taste of it. And then in terms of, you know, just the quantity that you have to consume, they're the low volume prep options. So, you know, there's a prep called soup prep, which comes in 2 little bottles that you can mix it in whatever you want, as long as it's a clear liquid, to mask the flavor. And it's a relatively small volume that you have to drink. Plus, you don't have to drink everything at once. You drink half of it the day before and half the morning of. So that makes it a little easier. They're coming out with the tablet preps as well, which is just, you know, if you don't have problems swallowing tablets, it's a lot of tablets. You know, I don't think we've made too much advancement in terms of, you know, how can this be a pleasant experience. but I think most people get through it just fine. But the industry is definitely trying to work on it. I think that we haven't gotten over the fact that you need a relatively large volume of fluid and a laxative that kind of tastes a little unsavory to flush the intestines clean. Maybe one day we'll learn how to just go in and power wash everything. We'll do all the work for you.
On that subject, I want you to talk about a myth, and that is, you know how you prepare for a colonoscopy, you clean out the bowels so that it'll be easier for the doctor to work at seeing that. What about these people that say you should clean out your bowels on a regular basis?
Oh yeah. You know, somebody, one of my residents kind of asked me that the other day, and they don't teach us much in medical school about that because that kind of falls into the more holistic type of medicine. I think that if you do that and you find that it gives you some benefit, like it gives you more energy, you feel kind of lighter, you feel healthier, and it doesn't cause any damage to you, then I think that's okay. But as a medical professional, like recommending it, I can't really go on record and do that. Just because it's not really part of conventional practice, and I don't know too much about it. I don't do it myself. You're talking about like colonics and that kind of stuff, coffee enemas, colonics.
Yeah.
So, hello. Yeah, I remember when I was small, my mother used to give us laxative once a month, either castor oil or
Yeah, you want to talk about something that tastes bad?
yeah, to clean our bowel, all the children, every Saturday, the first Saturday of every month. And then we were doing it, and when I grew up, when I came to the United States, I stopped it. And then sometimes I wonder whether that is part of my constipation. Whether I should refer to what my mother taught us when I was little.
Yeah, I was a victim of the castor oil thing too, in Jamaica growing up. But if you find that you need to do that, then I think that your daily regimen is probably not okay. I think focusing more on, evacuating yourself daily so that you don't feel this build up that you have to do like this big laxative day. That's going to be better for you.
Okay, thank you.
Yeah.
Good afternoon. My question, and again, thank you so much for that presentation. It was awesome. I actually had to make sure my husband came in and listened to it.
Oh, great.
But my question is, if a person has to take a lot of medicines for different ailments, does that have anything to do with constipation or?
Yeah, it depends on the type of medication that you're taking. We know some medications can definitely cause constipation. Especially like pain medications. Or pain
medication.
Yeah, that
my
definitely.
Husband's a diabetic, and he has bottles and bottles of medicine. So I just wondered whether that.
Yeah, that definitely will cause constipation. But adding the fiber hydration, if heart and kidney doctors are okay with that, and a laxative as needed, should improve that.
I've heard you mention several different laxatives. What about Colace?
Yeah, Colace is fine. The one that's I would avoid is Senna. Because it the way that it causes laxative, it forces the intestine to contract. So if you get used to that and then you stop taking it, then it can cause rebound constipation issues. Yeah.
I started using Colace. Well, I had it here simply because as my mother aged, that was what they prescribed for her. So since it was available, when I needed it, that's what I used, and I just kept on using it. So, okay, very good. Thank you.
Yeah, my pleasure.
Well, thank you very much. Any other questions? We've had Dr. Nembhard for over an hour now, and she's done a spectacular job. And if there aren't any other questions, I want to thank you so much for. You have a question, Dr. Deutsch?
Dr. Callender,
Yes,
Go
go
ahead.
ahead.
can you? Yes, I have a comment. First, I want to say, like everyone else, this is just awesome. Really appreciate it. I'm a wellness coach, health and wellness coach, and sometimes I need you in my back pocket because I work on the prevention. And just quickly, my mom is 95 years old, and we rotate her because she cannot live by herself. And I'm gonna what happened was she came from my brother one summer, and after sitting, and I'm a very active person, and because I'm a girl, she talks to me more about her body, right? So she began to tell me what she could not do. So I went into action, and this is one of the things that I recommend to my clients, which is mostly my family, friends, and neighbors. And I recommend it because it's an herbal cleanse, and it's backed by a medical and scientific board. I gave her this, and I gave her this because she did not have enough in her system. Even though I fed her oatmeal every day and things, but I knew that this worked because I've tried it, okay, on myself. And then, of course, I did the green powder on her, which gave her to steaming the collard greens, the kale, everything every day. I added this. And with these products, my mama was constipated to the point that she just couldn't do anything. I mean, absolutely nothing. She would try, and it was a whole list of things I did, but these are the three main ingredients that I did with her. She wasn't getting enough fiber. That was the first thing. She wasn't moving. All those preventive things you said, I really thank you, because it makes me feel good hearing it from specialists and a professional, that I thank God that I'm doing the right things to encourage people to do these things. So I just want to say thank you. And my 95-year-old mom, thank you. Now I can tell my sisters and brothers.
It sounds like you're taking good care of her.
One. But I thank you. I just want to say thank you. And thank you to the whole group.
Okay. Thank you very much, Dr. Nembhard, and thank you, group, for letting us spend another week together. Look forward to talking about some of our newspaper articles next week.
Yeah, thanks,
So,
Dr. Callender. Thanks, everyone.
Thank you very much, Dr. Nembhard.
Thank you, everyone. Thank you, everyone.
All right.
Thank you.
Bye.
Bye.
Okay, goodbye, everyone.
All righty. Let me see if I can get this applause thing to work. Nope, can't get it going.
Okay, have a good weekend.
All right, everybody. Thank you.
Bye-bye. Hey, John.
Hey,
Yeah.
all right, see y'all later.
Hi, Carol.
Okay.
I'm gonna stop the recording.
Finally.
Yeah, it came 15 seconds later.
Well, you'll know better next time.
Yeah, started 15 seconds before the end.
Bye-bye.
Okay. See y'all later.